Today we're going to dive into drug hypersensitivity and related allergic reactions, including urticaria, angioedema, hereditary angioedema, and cold urticaria. These conditions are important because they overlap with one another, and some can become life-threatening very quickly. Let's start with hypersensitivity. Drug hypersensitivity is actually the leading cause of fatal anaphylaxis, responsible for about 43% of all anaphylaxis deaths. The risk is highest when medications are given parenterally, meaning intravenously or intramuscularly, but in truth, any route of administration can be dangerous. Skin rashes are among the most common drug-related reactions, and they occur in about 2 to 3% of hospitalized patients. We divide drug reactions into immediate reactions, which occur within 1 hour of exposure, and delayed reactions, which occur after 1 hour, sometimes even days or weeks later. Immediate reactions are usually IgE-mediated type 1 hypersensitivity. Classic examples include penicillins, cephalosporins, quinolones, platinum-based chemotherapy, and monoclonal antibodies. These reactions can show up within seconds to minutes when given intravenously, or in minutes to an hour if taken by mouth. Delayed reactions are usually type 2, type 3, or type 4 hypersensitivity. These can present as hemolytic anemia, thrombocytopenia, neutropenia, vasculitis, drug fever, or serious skin reactions like Stevens-Johnson syndrome or toxic epidermal necrolysis. One especially dangerous delayed condition is DRESS syndrome, also called drug-induced hypersensitivity syndrome. It presents with fever, rash, and multi-organ involvement, sometimes with eosinophilia and hepatitis or myocarditis. It can last for weeks to months even after the drug is stopped. Common culprits include anticonvulsants like lamotrigine or phenytoin and allopurinol. Let's review the different hypersensitivity types. Type 1 is immediate, IgE-mediated, and can cause anaphylaxis. Type 2 is cytotoxic, antibody-mediated cell destruction, which may cause hemolytic anemia, thrombocytopenia, or neutropenia. Type 3 involves antigen-antibody complexes, leading to vasculitis, serum sickness, or drug fever. Type 4 is T-cell mediated, appearing days to weeks later, and can cause conditions like Stevens-Johnson syndrome or toxic epidermal necrolysis. On top of these, there are pseudoallergic reactions. These mimic drug allergy, but no immune mechanisms are involved. They're often triggered by radiocontrast agents, opioids like morphine, vancomycin, aspirin, and NSAIDs. They can still be severe, so the patient must avoid the triggering agent just as they would with a true allergy. Now let's move to urticaria and angioedema. Urticaria, or hives, is a type 1 hypersensitivity reaction of the skin. It's very common. Up to 20% of people will have at least one episode in their lifetime. Urticaria presents with itchy pink or red papules that evolve into larger wheals and plaques. If it lasts less than 6 weeks, it's considered acute. If it persists or recurs daily for more than 6 weeks, it's chronic. The main treatment for urticaria is second-generation H1 antihistamines, like cetirizine, loratadine, or fexofenadine. These are preferred because they're less sedating. First-generation antihistamines like diphenhydramine work, but their drowsy and anticholinergic side effects make them less ideal. For more severe cases, corticosteroids may be used briefly. For patients with chronic urticaria who don't respond to antihistamines, omalizumab, a monoclonal antibody against IgE, can be very effective. Angioedema often occurs alongside urticaria, but it involves swelling deeper in the subcutaneous tissue and mucous membranes. It's most often seen in the lips, eyelids, tongue, airway, or GI tract. There are 2 main types: mast cell-mediated angioedema, which is histamine-driven. This can be allergic in nature, triggered by foods, stings, latex, or drugs, and should be managed like anaphylaxis with epinephrine, antihistamines, and corticosteroids. Bradykinin-mediated angioedema, which is not allergic and not histamine-driven. This type is often triggered by ACE inhibitors and does not respond to epinephrine or antihistamines. Instead, it requires specific therapies like icatibant, C1 inhibitor concentrate, or ecallantide. Next, let's talk about hereditary angioedema, or HAE. HAE is a rare autosomal dominant genetic disorder where there is either a deficiency or dysfunction of C1 inhibitor protein. Without enough functioning C1 inhibitor, bradykinin production goes unchecked, leading to recurrent swelling attacks. The swelling is non-itchy, not associated with hives, and commonly affects the extremities, face, airway, or GI tract. Attacks peak at about 24 hours and then resolve over 2 to 4 days. The most dangerous complication is airway obstruction due to laryngeal swelling. Epinephrine, antihistamines, and corticosteroids usually don't work for HAE. Instead, treatments include C1 inhibitor replacement, recombinant C1 inhibitor, icatibant, or galantide. Nursing care includes close airway monitoring and readiness for emergency interventions. Finally, we'll finish with cold urticaria, which is a type of physical urticaria. This condition occurs when cold exposure triggers mast cell degranulation and histamine release. Patients develop hives, swelling, or even systemic symptoms after exposure to cold objects, fluids, or air. It is IgE-mediated and most often affects young adults, sometimes lasting 5 to 6 years before resolving. Most cases are localized, like redness and itching on the skin after touching something cold. But systemic reactions can occur, especially if a person swims in cold water, and these can be severe, even leading to anaphylaxis. Oropharyngeal swelling from cold foods or drinks has also been reported. Diagnosis is confirmed with the cold stimulation test. Applying an ice cube in a plastic bag to the forearm for several minutes and looking for a wheal and flare response after rewarming. All patients with cold urticaria should carry an epinephrine auto-injector. Pre-treating with antihistamines before cold exposure can help, and in severe or resistant cases, therapies like omalizumab, leukotriene receptor antagonists, or desensitization may be used. Nursing management is centered on prevention and patient education. Patients need to avoid triggers like cold swimming pools, cold operating rooms, cold IV fluids, and cold foods or drinks. They should always test water before swimming and wear protective clothing when exposed to cold environments. So, to summarize, drug hypersensitivity can range from mild skin rashes to life-threatening anaphylaxis, and it includes both true immune and pseudoallergic reactions. Urticaria and angioedema are common manifestations, but the cause and treatment depend on whether they are histamine-mediated or bradykinin-mediated. Hereditary angioedema is a genetic disorder that requires specialized therapy and vigilant airway management. Cold urticaria is a physical allergy that can progress to systemic reactions, making prevention and education essential. These conditions are reminders of how the immune system, while protective, can sometimes overreact in ways that threaten life. As nurses, our role is to recognize, prevent, and manage these reactions while keeping patients safe and informed.